you could just give us a quick review about what you talked about with cryotherapy specifically, but also in the framework of salvage therapy for prostate cancer.
Sure, yeah. We had the entire plenary dedicated towards management of patients who had radiation for prostate cancer as primary therapy and then had recurred. And so in that space, it's there's not a lot of data, and it's a challenging clinical situation. Therefore, we had a plenary debate about the best way to manage those patients. There are several options ranging from observation, androgen deprivation therapy, salvage cryotherapy, HIFU, and then salvage radical prostatectomy. And I think historically, radical prostatectomy has been the management option for those patients, and that procedure is technically very challenging and comes along with significant complications to the patients, particularly in the form of urinary incontinence. So our field has long been looking for alternatives to best manage those patients. I was defending cryotherapy,
Yep.
and there is data available, but it's all retrospective. There's no level 1 prospective data looking at cryotherapy in the salvage setting versus something else. And so I went through and I looked at the data comparing salvage cryotherapy to radical prostatectomy to ADT, and I looked for information on HIFU, and there haven't been any comparative trials yet.
Right, and on that note, this won't take you too long, but what do the guidelines recommend for salvage therapy in terms of cryotherapy?
It's in the guidelines as a possible option for patients who have radio-recurrent prostate cancer. The guidelines do note that radical prostatectomy is also a management option, but on the topic of guidelines, the AUA is currently constructing guidelines for salvage therapy for these patients. Right now, they don't exist.
Exactly, yeah, and I think there's so much work to be done. How do patient and disease characteristics influence where you go?
Yes, and I think that was that was maybe why cryotherapy did not win the debate, because our patient in that scenario was approaching 80 and had a low PSA and grade group 2 disease. But I think when you're considering salvage therapy, things that are important, parameters that are important to consider are the patient's age and life, not age, but life expectancy is what's important. So you want a life expectancy at least of 5 years. Then PSA is important. If the total PSA is less than 5, your patient has a higher likelihood of success with salvage therapy. And then PSA doubling time, slower is better than really rapid doubling time. And your patient's priorities, what is their sexual function, what is their urinary function? It's very much a shared decision-making process. I would say that imaging now really kind of plays an important role as well, as we've improved our imaging modalities and our understanding of prostate anatomy that can impact what salvage therapies are available. Lesion location, gland size, all play a role.
Right, and given that we're trying to minimize toxicities, how do you talk to patients about what they could expect with cryotherapy? What are some side effects? And kind of counsel them about it.
Patient counseling is paramount. At the end of the day, you don't want a patient who is cancer-free but has a very poor quality of life. And I think counseling them on all of the possibilities, including significant urinary symptoms, potentially significant urinary incontinence, urgency, frequency, and erectile dysfunction is really important. And so you have to assess what their function is after radiation, which is often diminished in an older population who's been treated. But I think that's kind of an interesting place to fit in focal therapies, and I would advocate for the right patient focal salvage cryotherapy or HIFU to try and keep the disease at bay while minimizing the side effects of the treatment.
Okay. And on that note, who would be the most ideal patient who you're like, this is someone who, I think if we get a little bit more data, it would even be better, but this is someone who really should be considering it.
Considering focal?
Considering focal.
I think it's pretty similar to how you would treat a patient in the primary setting, that being a gland size that is favorable for, for focal therapy, and a lesion that is identified on MRI, and when you do your biopsy to confirm that there is cancer present, that is the only place where you find cancer. If it's cryotherapy, generally posterior lesions are more accessible than anterior lesions. Right. I'm sorry, if it's HIFU, posterior lesions are better. For cryotherapy, you don't really have those restrictions.
Okay. And in terms of Gleason grade group, would that play a role at all?
Grade group plays a role. I think a lower grade group leans more towards surveillance for a patient, and a higher grade group lends itself to pursuing treatment in that setting.